Welcome to the Emergency Medicine Cases podcast. I'm your host, Dr. Anton Hellman, bringing you the brightest minds in emergency medicine from around the world. EM Cases is brought to you by SHREMI, the Schwartz-Reisman Emergency Medicine Institute. That's a nonprofit organization dedicated to improving EM care through high-quality research and education. The opinions expressed on this podcast are intended for information and education purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician. This episode is brought to you by Easy Resus, the resuscitation assistant. This amazing app has drug dosing, equipment size calculation, treatment algorithms, all in under 3 clicks. Rapid access to life-saving critical info in a user-friendly interface. Try the app for free with the promo code EMCases or visit easyresus.com/EMCases. That's easyresus.com/EMCases. In part 1 of this 2-part podcast on how the experts think, we covered pre-shift prep, tips while on shift to keep you sharp, how to think before, during, and after a resuscitation. And in this part 2, we'll talk about how master clinicians think in complex, non-resus cases, and what we can do outside of our ED shifts or after our shifts at home to improve the way we think and perform in the ED. We'll discuss how the master clinician thinks about history taking, physical examination, how they develop a differential diagnosis, test ordering, test interpretation, cognitive debiasing, how they use heuristics, decisions around treatments, how to best document to improve your performance, and then outside of your shift, we'll touch on all kinds of performance-enhancing strategies, from stress inoculation training to strategies on managing adversity, to decision-making journals, to deliberate practice and mental rehearsal, and maybe even more, although we'll see how much time we have. Welcome back, gentlemen. Dr. Strayer, Dr. Betzner, and Dr. Weingart.
Thank you. Pleasure to be with you guys.
Likewise.
Hey.
So let's start with history taking. Now, well, history taking sounds pretty elementary, and we might all think that we're pretty good history takers. I suspect that the master clinicians get the diagnosis right probably a little bit more of the time than most of us do, and it's probably because of their history taking skills mostly. I liken it to the data on self-perception on driving skills. So the vast majority of people, when asked if they think that they are excellent drivers or not, say they are. But when their driving is actually looked at objectively, most of the people who rate themselves as excellent drivers are actually poor drivers. It's intuitive too. I mean, all you need to do is drive for a few minutes in any big city like downtown Toronto or Manhattan, and you know that many, many drivers suck. And history taking is probably the most important skill in medicine. So this part of the podcast is not just for the medical students listening. This is even for the veteran EM docs. So to drive home the importance of taking a good history, we really should have the diagnosis in about 90% of the cases by the time we're finished taking that history. So let's start with Dr. Strayer. Could you go for us how you take a high-yield history from a patient in the ED?
Well, thanks, Anton. I'll start by taking exception to the way you framed the enterprise by looking for a diagnosis. Of course, looking for a diagnosis is not what we do in emergency medicine. We're not as concerned about what the patient has. We're concerned about what the patient needs. Along those lines, I learned very early on that the tools that we were given in med school to assess a patient don't work very well for us in the emergency department. So to take everyone back to those dark days, you would start with a comprehensive history, including family history, including an assiduous review of systems, which would lead you to a preliminary diagnosis, after which you would perform batteries of ancillary tests to arrive at the final diagnosis, which would allow you to initiate treatment. And that's the paradigm that we all came into medicine with, that we learned in med school, and it doesn't work for emergency doctors for a variety of reasons. That said, it's served me well to approach history taking in all non-critically ill patients with a framework and a pattern. And the easiest trap to fall into as an emergency doctor is to walk into a room, ask, how are you and what brings you in today? And then fall back on your gestalt, your instincts, your type 1 thinking to let the diagnosis or the management plan just sort of wash over you. And the older that you get, the more experience you get, the more likely you are to be right about that management plan. But when you are more deliberate about structuring your history, you're going to come up with a better plan more often. And so I'm pretty vigilant about how I approach a non-critically ill patient, and I go through a number of data points even before I allow myself to approach the patient, and then I don't let the patient tell me why they came to the emergency room on that particular day until I've gotten a few data points out of the way. And I'm happy to go through those data points if you want, but maybe we can talk more holistically about how the others approach history.
I'm eager to find out what your data points are, but yeah, let's hear from Dr. Weingart and Dr. Betzner in general, in a global way, how they approach history taking in non-resus emergency patients.
Sure. I'm going to not say too much here, except that Ruben's absolutely right. What works for internal medicine, which is a stopgap against missing things. The reason they're so systematic and arduous in their history and physical is because they're supposed to pick up the things that we missed, the things that fell through the sieve. Emergency medicine works on a hypothetico-deductive methodology, which essentially means we're using both simultaneous inductive and deductive reasoning. Essentially we're looking for clues, but at the same time we're postulating hypotheses that guide our further history and physical taking, which allows us to be incredibly concise and yet usually not miss things. The way you have to utilize that rapidity is when things don't make sense, you then have to go back and fall back on the internal medicine style of incredibly extensive history and physical. But for the most part, you can discern very quickly what you think the possibilities are for the life threats you're going to rule out and then an actual diagnosis. And then you check your work. And if you do that, you could be incredibly rapid, but at the same time not have things missed.
Yeah, I agree with all of that. And I certainly agree with Ruben. I actually never go in the room without looking at a whole bunch of things first in every single patient. So the nursing notes for sure, the EMS record for sure, all of the vital signs that have been recorded so far for sure, any medication record that's available to me for sure, any transfer notes from nursing homes for sure. That only takes a few minutes to do, but I do it 100% of the time because I always want to address discrepancies, which are frequent in the stories provided by different parties involved in the care of the patient. And I want to build that, database in my head before I go in the room to start talking to the patient of what's going on. The other thing I just really want to make a point about talking about is, and I really make this point with my residents, is I have a rolling workstation. We all work on computers now, is put those damn computers away when you're in the room and look at the patient and watch the patient as you get them to tell you things and talk about eventually why they're there and go through whatever construct you use for getting the information out of the patient, because nonverbal cues are missed all the time by people that take poor histories. And resident will tell me one thing, I'll go in the room and watch the patient giving the same information, then interrupt them multiple times. As you can tell, there's something else they want to say, but it hasn't been allowed a chance for them to say it because they've just skipped to the next question, a la what you were talking about as people go through these internal medicine constructs. So pay attention to the patient non-verbally at all times, because there's gold there. That's a big thing for me.
All right, Dr. Betzner, you had mentioned a few data points that you gather before you even start taking the history. Dr. Strayer, did you have any other data points you wanted to add to what Dr. Betzner said?
Let me just reinforce how important it is to review the information that's available to you before you go see the patient. It's really tempting, especially early in your career, to click on 16 patients and then just run from patient to patient and just try to see what's going on with them. And this is how you miss stuff. This is how you develop poor plans. See one patient at a time, as we discussed last time. When you click on your patient, when you assign yourself to a patient, you look at the vital signs first. Vitals are vital. Make sure that the vitals comport with the area in the emergency department where that patient is. How often do we see a patient triaged to a subacute area with an alarming vital sign? Often that vital sign was recorded incorrectly. Sometimes that vital sign was not recorded incorrectly, and that patient should have been triaged to a different part of the emergency department. So I always start with the triage vitals, and then I look at, because it's using the same place, I look at the triage nursing note. Ignore the triage nursing note at your peril. The triage nursing note is where much of the gold in the history is found, because the triage nurse talked to the EMS providers who knew a lot more about what was going on before the patient arrived, often than the patient did. So you get an enormous amount of useful information from the triage nursing note. You also want to look at the EMS run sheet along those same lines if it's available. Along the same lines, if you see EMS drop off a patient, talk to them because they often have really useful information that may not be recorded in the triage note and you may not have access to their run sheet. The one thing that Mike didn't mention that I think is really relevant to every patient that you encounter in a non-resus environment is to look at prior visits. Is this someone who was here yesterday? Is this someone who's been to the department 6 times in the past 6 weeks? Or is this their first visit? An enormous amount of useful information can be gleaned from looking at prior presentations to the emergency department, prior clinic visits, prior hospitalizations. And then once you've looked at prior hospitalizations, nursing notes, EMS run sheets, vitals, and then you've scanned their chart for things like medications, past medical history, try to get a global sense of what the patient is all about. At that point, you're ready to approach the patient, and then I use a very structured approach in my interview as well.
Yeah, I don't disagree with any of that, Ruben. I review all that same information. I think you have to be a little bit careful, though, about especially repeat presenters, about not kind of getting on your blinders when you read that past history, especially when they've come in with the same thing 50 times, in the last month. So just be careful about that. That can lead to us going down a rabbit hole of just staying focused on the black part of the hole and not looking at the edges.
Can I specifically comment on that? Because I have heard people recommend that you not look at prior visits.
No, I disagree with that. Yeah, I disagree with that, but I purposely force myself to give that patient a chance to tell their story independent of that information as much as I can. I would hope at least. I really try to let them tell their story at least once.
The idea that you should not avail yourself of prior visit information is lunacy. Of course, you need to know about prior visits. It's essential information. Also, you need to know the potential for that information to mislead you.
Exactly.
All right, there's a lot of stuff in there. Data gathering, it seems, is very important even before you see the patient. We've talked about EMS run sheets, prior visits, nursing notes, vitals are vital. All right, so that's about data gathering. Now you're walking into the room and taking the history from the patient themselves. Dr. Strayer, you had mentioned that you don't ask them why they came to hospital at the top. Could you explore that further for us? Because I think many of us do want to know from the beginning why they came, and it also helps to focus the patient on the chief complaint rather than them going off on a tangent from the beginning.
Sure. The heuristic here is leave the obvious for last. And the reason that heuristic I think is important is because you are not going to forget to ask the patient why they came to the emergency department. That's something that's on your mind, and it's most certainly on their mind. This becomes even more relevant in the physical exam, where leave the obvious for last compels you to not, for example, examine the abdomen first in a patient with abdominal pain. Because if a patient presents with abdominal pain, you are not going to forget to examine the abdomen, but you might forget to examine the oropharynx, where something important might be located. In the same way, if you walk up to the patient and ask why it is that they came to the hospital today, you will be going down that journey with the patient down whatever path they want to take you. Some would say that's an advantage to that approach, and I respect that. But I have found that when I force the patient to give me a little bit of information at the outset, that I can be much more efficient in my data gathering because I frame their history of present illness, the reason they came to the emergency department, I frame it in a larger context. So, for example, things that I want to know before history of present illness are there major medical problems? Because a patient who comes in with abdominal pain, who has a history of 4 stents and a cabbage, is a different person than that same aged person who has no known history of coronary artery disease but has type 1 diabetes. The past medical history frames the chief complaint and frames their history of present illness, so I want to know it first. And so I just ask, what medical problems are you known for? Diabetes, high blood pressure, heart, lungs, liver, kidney. The next thing I ask about medications. what major medications do you take every day? I ask about recent changes in their medication profile, which contribute to so many emergency department presentations: missing meds, non-compliance with meds, extra doses of meds, medication changes. I ask about their functional status. I ask who they live with, what their living environment is. And my residents like to make fun of the Strayer approach, where you always ask about a social history, but I don't understand how you come up with a disposition if you don't know what you're sending the patient back to. So I always want to know, what's the living environment? Do they live with 24-hour home health aide, or are they living by themselves? I ask about substances. Long before I got interested in addiction, I knew, and we all know, that recreational substances, specifically alcohol, tobacco, and opioids, contribute to so many emergency department visits. And I think it's really relevant to ask in a non-judgmental way, what substances do you use every day? And you'll get a lot of useful information that way. Only after going through that background information, which in most patients takes me about 1 minute, maybe 2, will I then recruit the reason they came to the emergency department today. What brings you to the hospital today? And now I can interpret that information in a context that I find more useful.
That's a really interesting approach. I mean, I think most of us don't do that, but just to clarify there, you're asking the stuff that you might forget to ask off the top. So you start with past medical history, medications, social history, and substances. I'm going to try that myself and see if it is higher yield for me, because I think most of us don't do it that way. Dr. Betzner, any thoughts on that sort of approach? Is yours similar, or do you do the sort of why are you here off the top and then go from there? Or is it, there's other people who advocate sort of a narrative approach where you just let the patient talk and tell their story, and that often just out of their story you can get so many pieces of data to help you form your most likely diagnosis, et cetera.
Yeah, I would definitely be of the varietal that lets the patient tell the story of why they're there from the outset. Now, having said that, I ask every single question that Ruben just talked about every single time, unless it's the most minor of, ridiculously minor presentations. But I always ask that exact information. I just don't put it at the top. And I let the patient tell their story, and then I'll build the construct around that story with other information that I've already got, per that review that we've just talked about.
Any other comments about data gathering and history taking?
I think it's important, for me at least, if something isn't making sense, to go back to other sources of information. Go back and talk to the bedside nurse. If the bedside nurse is on break, find her or him and talk to them about what they have, because sometimes they haven't written it all down yet. And so again, I just listen to my gut. The older I am and the more experience I have over time, boy, if something doesn't feel right, I'm going to spend a lot more time getting information from other sources that have been watching the patient, or getting information from family, or I'll talk to family, of course, or talk to their regular physician if necessary, et cetera. That other information is key. If it's not adding up, you need to spend time figuring that out.
Totally agree. All right, so that's a bit about, or actually that's quite a lot about history taking and gathering data. I want to move on to physical exam. And you touched on this a little bit, Dr. Betzner, with actually just observing the patient. It seems like the more great tools that we have at the bedside, like POCUS, and the more fancy tests we have access to, like triple contrast CT or MRI, the less we seem to depend on physical examination, and the more our physical examination skills get degraded over time. I think we'd all agree that William Osler probably had better physical exam skills than we all do, at least in part because he didn't have access to all those fancy machines. I fully admit that sometimes when it's really busy, I cut corners on the physical exam, and then later on, occasionally in retrospect, I realize that I could have picked up some key diagnosis if I had done a better physical exam. And I guess a lot of us would admit that we cut corners sometimes on the physical. Now, I'm not saying that we need to do like a 15-minute full neurologic exam on every neuro patient, but we shouldn't do a crappy cursory exam either. I think another reason we cut corners on the physical exam is because if you look at the likelihood ratios of any single physical exam maneuver, the vast majority of them are pretty weak. And there's all kinds of studies that make these conclusions that say the pelvic exam has poor evidence for ruling in PID, so we don't need to do a pelvic exam. for example. So let's talk about physical. First, what's your reaction to everything I've been saying about our degradation of physical exam skills? I mean, I hear all kinds of opinions all over the map about this.
Well, I think this is a function to some degree of our departments being horrendously designed, horrendously overcrowded. Nurses and other folks that are meant to help us not having the time to do so adequately. So, as an example, no one that I see anymore is undressed in any fashion for anything ever. They're never in a gown. They never have their clothes off. Their wounds are never cleaned. This has just become a thing of the past. So what that has translated into is this acceptance of patients being seen in chairs and hallways and non-private areas with all their stuff on, with very poor preparation. And that is what we need to get rid of. And I'm a huge stickler with my students and residents about get patients undressed, look at both sides, look at front and back, feel front and back, because there's tons of stuff that we miss because people are clothed and in poor situations for examinations at all, let alone good examinations. So that's point number one. Point number two is I think there's the real money in examining patients is in the distracted exam. And this is kind of a takeoff of what you were talking about, Ruben, in terms of your history. Get all this other information and then let the patient tell you their story. But I'll do that, but I'm also examining the patient relevant to the presenting complaint as they're telling the story very frequently, because I want to see what their reaction is. Well, and I ask their permission. I'm going to be checking some things as we're talking. I want to see what their distracted reaction is. Not, I ask them once, where's the belly pain? Where are you having trouble? Kind of thing. But then I do multiple laps around the belly to see what they react and how they react without me asking them, does it hurt? Does it hurt? Does it hurt? I never do that, ever. I let them tell the story once and then I never ask them again. So distracted exam, I'm a big stickler up. And finally, get old patients, people with general malaise, anybody with neurologic complaints, get them up yourself and walk them around the emergency department yourself, at least a few steps, because it makes a disposition decision instantaneous for many of these patients. That is irrespective of any test that you're going to do, whether they're going to come into the hospital or not. People that can't sit up, can't get out of bed, can't ambulate without assistance are coming into the hospital. And a lot of times, I well, give me this whole story and their whole exam, and you get that patient up. And no, they haven't done it. And they haven't made a disposition decision that would have been very obvious if they have just done that one basic thing. So that's what I have to say about it. I don't think we should accept our current working environment as a reason not to examine patients. Examine your patient. Find a place to examine your patient properly.
Couldn't have said it better myself. Dr. Weingart, Dr. Strayer, any comments about physical exam?
Yeah, absolutely. If you have a patient who you are going to get a trauma CT on, they're 70 years old on Xarelto, they need a trauma exam, but they don't need the extensive trauma exam of the patient I'm sending home, right? That's a different patient. And maybe everyone's doing exactly the same in both of those. But for me, it's a very different scenario. I will absolutely put out that Mike's statement about distracted exam is absolutely key. That's the pro-level move, is to never elicit tenderness by saying, does this hurt? That is the mark of an amateur. The mark of an expert is it hurts because they grimace and grab your hand because they're telling you their story and you're gently pressing on their neck during a C-spine clearance or their abdomen during an abdominal exam. So for me, it's back to that hypothetico-deductive method. My physical exam is being generated by my hypothesis as I am talking to that patient.
Dr. Strayer, any comments on physical exam, how you approach physical exam?
I think that we can agree that for most patients, the management plan and our differential is driven primarily by the history, and that the exam can be done in a more directed fashion. And I think the idea that we need to be doing a comprehensive exam is one we can dismiss out of hand. There is no such thing as a comprehensive exam or a standard exam. There's no patient who needs a routine or a rote type of exam. After you do your history, you've started making a differential. You're going to do your review of systems at the end of your history, but not a comprehensive review of systems, but a review of systems based on your dangerous differential, the conditions that you want to exclude. Each question that you ask in the review of systems should be directed at your differential. So after you've done your full history, whatever that means for the patient in front of you, for example, for a headache, you now have your list of 5 dangerous headaches that are left from your list of 13 dangerous headaches. You're now left with 5, and now you ask your review of systems tailored to those 5 remaining conditions. Once you've completed that, you're ready to move to your exam. And the exam need be only as comprehensive as dictated by the remaining elements of your differential and your management questions. So, for example, in a patient with abdominal pain, you want to be thinking about the dangerous causes of abdominal pain. And in most North American emergency department environments, the focus of care, once you have determined that you're not dealing with a non-abdominal cause of abdominal pain like coronary ischemia or DKA, is whether or not you're going to perform a CT scan of the abdomen. That is the decision point that's going to drive care in most cases. So, for example, once you've decided that this patient needs a CT of the abdomen, you don't need to spend very long pushing on the abdomen. What you really want to know is there frank peritonitis? In which case, you would maybe think about calling a surgeon before getting the CT scan. Now, in point of fact, I would probably just push that patient to CT scan immediately because the only thing the surgeon is going to ask you to do is get a CT scan. But there are no routine elements of the physical exam. Every element of the physical exam, every maneuver of the physical exam should be thought of as a test with its own positive likelihood ratio and negative likelihood ratio. And so there's no reason to spend time doing maneuvers on the physical exam that aren't going to change your differential and your management plan. And so the physical exam in almost every patient should be highly focused toward your differential. The caveat to that is the patient where you have a very limited history. In a patient where you have no idea what's going on because they can't tell you anything, because they're unconscious and you have very little pre-hospital information, that's when you need to take a step back, recognize the limitations of your history, and try to fill in those gaps with a much more careful physical exam. So for the patient who can tell you what's going on, they have a normal mental status, you get a good history, you have a clear picture of what's happening with that patient, your physical exam most of the time can be very directed. In the patient where you have no idea what's going on, they were picked up on the street and now they have abnormal vital signs and they look unwell, well, that patient needs to be immediately stripped naked and every inch of skin examined, and a much more comprehensive and thorough and thoughtful physical exam needs to be performed in addition to a much more comprehensive set of ancillary tests.
We've touched on the differential diagnosis and how you come up with the differential diagnosis and how it's different than the classic sort of internal medicine differential diagnosis and how we learned in medical school how to come up with that. I just want to dig into that a little bit further. You know, there's all kinds of approaches. There's thinking in 3 levels: critical, emergent, and common. Dr. Betzner, Dr. Weingart, is there any particular way that you go about forming a differential diagnosis?
I'll jump in because I'll just be 1 minute and then I'll hear the actual smart answer from Mike. For me, it's what my Gestalt tells me and then what is going to get me sued, what's going to get me M&M'd. And I run through those parallel pathways of what is jumping out at me, but then what am I missing? And that's the way I'm trying to really state is what would be something dangerous that could be left out of my initial Gestalt, even if it's rare. And then I start looking, did I cover that on history and physical? Ruben mentioned deadly cause of headache. And so, I will actually look at a list in my templates of headaches each and every time. And I see carbon monoxide and I realize I forgot to ask about that. Oh crap, it's winter. Oh man, what's going on? And then I'll go back in the room and ask them. So that's my differential is, my experience has told me a set of things that it probably is. And then I like to really go over what I can miss that's life-threatening because I don't care about the things I'm missing that aren't, and really make sure I hit all of them on the history and physical. All
right. So it's Gestalt, and then what dangerous thing are you missing?
Yeah, system 1 and then check it with system 2. Exactly right.
Great. Okay. And Dr. Betzner?
Yeah, I can't say I'm dissimilar to that at all. I mean, my pattern recognition at this point, I think, is pretty solid. I know what my patients have is I know what they ended up with because I follow everybody. So, Gestalt is huge for me. But I do always force myself in particular to think about things beyond the obvious, and in particular things that refer and produce symptoms in the area that's not obvious to the area. Abdominal pain, being a lower lobe, pulmonary embolism. Neurologic symptoms in different areas being, embolic from the heart or a dissection, that kind of stuff. And headaches can, I always force myself to think about PMR and giant cell arteritis and glaucoma, and I check the intraocular pressures every time when somebody has unexplained headache. I don't know how many cases of glaucoma I found over the years, just forcing myself to do that, even though my gestalt says it's something else. So yeah, I think I work very similar to what Scott is outlining for sure.
All right. So again, gestalt, and then I would say cognitive forcing strategies is another important thing, which there's all kinds of cognitive forcing strategies. Someone comes in with flank pain, always think about a vascular disaster, not just renal colic, etc. Dr. Strayer, any more comments before we move on from differential diagnosis?
Yeah, I'll briefly just say that I think, once again, the three of us have come to a similar place 20 years, 25 years into our practice. The two things I want to know from my residents, for example, when they're presenting to me, and the two things that I look for in myself as I'm formulating a plan are, number one, what do I think is going on? Is there a tidy explanation that accounts for this patient's presentation? So that's what Scott referred to as gestalt. Do I have a sense of what's happening here? And then I also have like this internal barometer of how confident I am in that diagnosis, in that sense of can I tie this all together in a way that I'm confident is the case? Or do I have a sense of what's happening, but I'm not really that sure? So that's one piece. It's like, do I have a sense of what's happening here? What is that sense? How strong do I feel that sense? And then at the same time, parallel to that, I am formulating my dangerous differential. And I believe that the most important knowledge, the hard skill of emergency medicine, is being able to link symptoms and signs to a list of dangerous conditions that apply to the patient in front of you. So early on in my career, I developed a relatively comprehensive list of dangerous conditions. And I think our perhaps cardinal skill is being able to choose from that list of dangerous conditions to decide which ones in that list apply to the patient in front of us. And you're doing that in parallel. And this is exactly what Scott referred to as System 1 and System 2 thinking. System 1 is, what's going on here? Is there something that ties this all together, and how confident I am in that story? And System 2 is, do I have that list of dangerous conditions, and focusing on explicitly and deliberately deciding which ones of those dangerous conditions I need to do further tests to rule in and rule out.
And now a word from one of our sponsors, Easy Resus, the resuscitation assistant. Easy Resus is thrilled to announce that they are now available for institutional access. In addition to providing the app for all employees in your organization, this means access to exclusive features like printable protocols with calculated medication doses, customizable content to fit your local protocols and practices, access to Easy Resus on computers via the web-based version, and much, much more. To learn more, visit the institutional license section at easyresus.com. And as always, you can download Easy Resus and use the promo code EMCASES, that's EMCASES, one word, to get your 2-month free trial on an individual subscription. Dr. Betzner, you had mentioned cognitive forcing strategies, or that's what I described as some of the ways that you think, kind of closely related, or even sometimes the same thing, is heuristics. I'd like to pick your guys' brains a bit about some of the Pearl heuristics that you use. There's a great list on MCRIT, so full credit to Dr. Weingart here, of some of the classic heuristics. There's, severe bradycardia / heart block is hyperkalemia until you actually see the potassium level come back. Slow AFib is dig toxicity, hyperkalemia, or nodal blockers until proven otherwise, et cetera, et cetera. Then there's some more sort of general heuristics like rule out worst case scenario, sick or not sick dichotomy, shotgunning. Any kind of key heuristics that you guys tend to use that have helped you along the way? Dr. Weingart?
Yeah. I mean, before I would even elucidate any key heuristics, this speaks to two mind of the resuscitationist concepts that we put out there. And some of the ones you mentioned from MCRIT are part of the functional heuristics project, which, there are some key heuristics you gain from experience that would be really nice to have had, really early on. You mentioned some of them, like others, like anytime you see rhabdo, it's compartment syndrome until you rule that out. These functional heuristics could really do a lot of work. So we've been trying to gather them. But the second concept I think is even more important, which we call heuristic cycling, which either the incorporated heuristics like hypo-K equals hypo-mag, Corey Slovis taught us all that. It's not true. It's been debunked. The study's been done. You could leave that in your career, from now until you retire, and you're going to be telling, from this point on, all of the residents a false paradigm. So you can't just leave heuristics alone. And that's the ones you've incorporated. The more dangerous ones are the ones you've built subconsciously, the ones that you never even knew they were happening. So heuristic cycling is every time you find yourself doing something by reflex, you write down, oh, that's a heuristic that I've incorporated. And then at some point, when you have some time for reflection, you ask yourself, is this heuristic still valid? Has it changed? Has some experience I've had in the past few years actually told me I shouldn't be using this heuristic, and yet I haven't really made the decision to get rid of it? So what you're taking is a system one action, which is what heuristics and cognitive forcing strategies are, and you're exposing it to the hard light of system two before you reincorporate it. So you might have a resident early on in their career say, because they've subconsciously incorporated it, every time I see a guy with flank pain who looks miserable, it's a renal stone. And then they get burned. It's a AAA. They've re-established that heuristic wasn't good. They've built a more functional one. You could force that to happen a lot more quickly by asking yourself every time you do something reflexively, is it still good or not?
I love that. So heuristic cycling, it's basically keeping up to date on your heuristics based on your own experience, others' experience, and the evidence out there.
And forcing you to realize what is heuristic action and asking yourself if it's still good.
Fantastic.
This comes down to what, in Scott's last point, trying to recognize within yourself what patterns you're responding to. Most of us have a hard time accessing that level of insight into our own behavior. And I think it requires a highly mindful approach to practice, which I think we can all encourage. Just recognize that knowing that you see someone writhing in pain with flank pain and immediately going to kidney stone, knowing that you're utilizing a pattern there, a heuristic, requires some degree of mindfulness and care.
The other thing I'll say, I just keep hammering on this point. If you don't follow your patients, you don't know what they have, right? We send people home all the time, and we're going to talk about this in a little bit about your tolerance level for risk and that kind of stuff. I don't worry about sending patients home at all. It doesn't bother me at all, but I also follow them all. And so I know when they come back, and I know what they came back with. But it is incredibly powerful to see what happens to your patients and see if they come back, not just in a couple of days, like most people have 48 or 72-hour bounce back notifications. That's helpful, but that's not where the gold is. The gold is in the patient that shows up a week later or 2 weeks later or a month later, and it looks like it's probably related to what you saw them about, and you didn't know it because you never looked. Pattern recognition gets better when you actually know what happens to people. It just does.
I think that's all we'll say about heuristics for now. In part one, we discussed a little bit about the importance of documenting, but I want to kind of reiterate again how important it is in the first place to document and how that helps you be a better clinician. There's a lot of reasons why we document. We document for billing reasons. We document so that downstream physicians can learn what we did on that day that we saw the patient. We document for defensive reasons, for medical legal reasons. But why is it important to document well in terms of your chance of taking the best care of the patient? And how does it help you think through the patient's case?
I'm going to take this for a second. We learn better when we write things down ourselves. Whether you write, it's actually better to write. This is an unfortunate reality of typing and dictating. It's actually, there's good educational literature that says it's better to write. Unfortunately, of course, most doctors can't write. But that aside, taking the time to sit and write, we learn, we process, you think, and I think come up with your overall gestalt of that patient partly comes with assimilating that data in a way that makes sense. And so it's part of our learning process, which is then part of our care process comes from getting that data down properly, at least in my mind. If I don't write it down in real time, by the way, not after the shift, we talked about this last time, with each patient, I can't provide good care to that patient. I need to think about it. I need to sit down and take the time to do that. With that in mind, I think we should avoid a bunch of stuff that is happening widespread at this point with these EMRs, and that is avoid auto imports. I hate them. They should all be eliminated, every single one of them. And I think every physician needs to have an actual summation that says, this is what I think was wrong with this patient, and this is my plan on their chart. It drives me bonkers when I see 15 pages of garbage and no summation and no plan. That implies docs that I don't think actually knew what was going on with that patient, or if they did, they certainly didn't convey it in any meaningful way, which often is why the patient is back a day later.
So that segues nicely into my next question, which is how do you document efficiently and well? Like, what defines good documentation, and how do you do that efficiently? Because especially in Canada, where there's patients lining the halls and we need to get through patients as efficiently as possible, how do you document efficiently and well? Dr. Weingart, do you want to start with this one?
Yeah, well, I don't think it's possible to do proper medical legal protection and proper avoidance of missing things that aren't immediately apparent to you by Gestalt without templates. And so for every major complaint that has a comprehensive differential, my template's there not just for billing efficiency, but because I force myself to read it each and every time. And this is, I think, the only safe way to use templates is to have them, but read them each and every time. Even if you just use it for the patient beforehand, you read it again. And that forces me now to consider all the things that smarter Scott was thinking of when he wasn't hungry and tired and needing to pee. And it'll keep me from missing stuff. But it also allows me to do very comprehensive protective documentation almost instantaneously. And it saves the time in my documentation period to put things like my thoughts about the patient, my feelings about why they are safe to go home, and all the other stuff. Because I mean, if you looked at my headache template, it would take me about 15 minutes, to type all that out. That might be a slight exaggeration, but at least 10. I don't have time for that. It's there. I read it. I've actually verified that everything on there is true, and then it goes in. And now I could actually save that time to say why I think it's safe for the patient to go home.
We can all agree that auto import or pasting into your note things that are already somewhere else in the chart is not only a waste of time, but it makes your note much less useful to the person who wants to read it later. The macros, I think we also are all in agreement that templates serve a role. And I'll just reinforce that the primary role of those macros is not to buff the chart, but to buff your brain and remind you of the kind of assessment that you want to do for this patient that you, as Scott said, his best, Scott, when you're not in the midst of a shift, but when you're actually thoughtfully considering the differential for headache. And you can only do this if you chart one patient at a time. This does not work. This extremely powerful feature of macros does not work if you save charting to the end of your shift.
100% agree.
Yeah, the danger with templates that I've seen happen is that people use the templates, but then they fill it out so quickly that they actually, they didn't do a proper neurologic exam, or they didn't do what was on their template. Again, they're cutting corners here and there, and their template is very robust, but they actually miss a whole bunch of things. And then it says in their documentation that they did do it when they actually did not do it. It's obvious what the dangers of that are. Any comments about how you design your templates so that they're reasonable and doable, and any comments about not filling out your templates adequately?
I could talk an entire course about that, but the one sentence that needs to be said is, if you're not reading it each time, that's when you're going to fall into that trap, Anton. If you put a comprehensive neuro exam in there and you read your template, you're like, I didn't do any of that. You delete it. It's fine. It's the people that use templates without rereading each and every time that are going to get burned. And it will burn you badly, especially in the States.
You can maximize the chance that you're going to use your template effectively by making your templates relatively pithy. The templates that go on and on and on and list 17 reasons why you're not pursuing a CT aorta, you're not going to read all 17 lines of that every time, so don't put in 17 lines. Just put in the most salient features. And it's also worth noting that you don't need to spend a lot of time justifying why you did certain tests. That's just not helpful. What you want to spend your time on in documentation is describing and explaining why you didn't go further on a particular diagnostic pathway. My residents will often, their plan will often be, well, I'm going to order a CBC, a chemistry, a blood gas. None of this really needs to be in your plan because we see it in the orders. What you want to explain in your plan is why you're going to withhold ordering a CBC, a chemistry, or a blood gas.
Let's move on from developing a differential and documentation in the complex non-resus patient to test ordering. So this has also changed a lot over the last few decades for obvious reasons. And where I work, for some reason, it's accelerated significantly just over the last 2 years for less clear reasons. Your test ordering volume will depend on your risk tolerance, your experience, your local culture, your patient's expectations, et cetera, et cetera. But I think there's a few key principles in ordering tests that can help us choose wisely when we think about ordering that D-dimer or that triple contrast CT or MR or what have you. Let's start with you, Dr. Strayer. How do you approach test ordering to help you narrow your differential diagnosis or land on a most responsible diagnosis?
Sure. Well, this all is driven by your comprehensive understanding of the list of dangerous conditions that apply to the patient in front of you. That's the cornerstone of emergency medicine knowledge that drives every single decision that we do in emergency medicine, or almost every single decision. So there are three types of patients. Three ways to think about patients who might need this test. There's the patient who clearly needs the test. There's the patient who clearly doesn't need the test. And then there's the patients in between where the patient might need the test. Some patients in this group will, and some patients in this group won't. And recognizing that is the first step to slowing down and being thoughtful about which tests you order for the patient in front of you, because the patient in front of you probably needs some series of tests, probably doesn't need some other series of tests, but might need a small number of tests that you're thinking about. This comes down to, in emergency medicine, a very small number of tests. Usually for labs, it's things like a dimer is the one that we struggle with the most. And then it's really more, does this patient need a CT? Does this patient need an MRI? For plain films and for your basic labs that we're ordering so frequently, we don't have to spend a lot of energy deciding whether or not that a patient in front of us needs those basic tests. It really has to do more with a couple of limited tests that I just mentioned. A thoughtful analysis will generally provide the answer, but I think an underutilized tool is when you're not sure, or more frequently, when it's reasonable to order the test and it's reasonable to not order the test, to engage in shared decision-making at that point and partner with the patient to decide whether they're interested in waiting for the test or not.
Yeah, well, I mean, let me just start with, we do way too damn many tests in general. We are bankrupting our healthcare systems with unnecessary investigations on all fronts, and it is going up. I really try to think about even CBCs, even the basic stuff I'm a stickler about. If there's not a good reason to do that that's going to change our management, we shouldn't do it. And my residents know that. They have to justify every single test that they order, including the basic stuff, to me every time. Because we just simply, don't need most of these things, especially when you've reviewed the medical record like we've just talked about, and the patient's already had XYZ tests very recently, and yet they're being done over and over and over again. That kind of stuff drives me crazy. So, I think risk tolerance factors into this. You have to have some degree of risk tolerance to just examine folks, take their story, and move forward with a plan that doesn't involve a bunch of other investigations. Think about your pretest probability before you press go on anything, and what you're going to do about that result, both positive or negative, before you press go on anything. That's all I have to say about it.
I think one of the ways to choose wisely with your tests came out of an article from decades ago called The 4 Principles of Diagnostic Decision Analysis. And I try and go through these 4 things every time I order a big test. So I'm just going to go through these and we can riff off of this. So the first thing is, in the diagnostic context, patients do not have a disease. They only have the probability of a disease. Number 2, diagnostic tests are merely revisions of probabilities. Number 3, test interpretation should precede test ordering. And I think Dr. Strayer had mentioned this in part 1. And then number 4 is, if the revisions in probabilities caused by a diagnostic test do not entail a change in subsequent management, use of the test should be reconsidered. And I think if every CT we order, every MRI we order, we think about these things, we'd probably be choosing more wisely. Dr. Weingart, what's your approach to test ordering?
Yeah, I'll say two things. The first is, and this might anticipate some of your discussion on risk tolerance, but I'll just risk that. In general, if we can, just by our initial history and exam, take a potential serious condition below 2% on our pretest probability, then we're pretty much done. And for these serious conditions, if in general you're above 10%, then we're going to test. And the space between them, between 2 and 10%, I like to call the plaintiff's gap, because that's the space where it feels like a real difficult sell for this patient who has, vague arm pain to turn out to be an aortic dissection. But the way you get to a 4% pre-test probability of aortic dissection is by having something very different than the classic. And we kind of play a game in emergency medicine where if you are a efficient and a little bit risk tolerant doctor, you'll generally start, whether you realize it or not testing in that less than 10% category. And most of the time you'll get away with it. Something else will cue you and you'll catch them before they go, or they'll find it anyway on an exam you've done otherwise. And you generally get away with that. But I think it's kind of ridiculous that we're in that circumstance to begin with. Having to drive a diagnosis like aortic dissection down to less than 2% when there really is no intermediate test at this current moment in time until the full test of a CT angio of the chest, it really puts you in a difficult situation. And people that feel that like, oh, no, I'm very, circumspect with my tests for aortic dissection, they're kind of fooling themselves and they're getting away with it. And it's fine. It's what keeps medicine functioning. But I just want to put out there that we are playing a little game with that. And if you really looked at it, you'd realize it. The other thing that I just want to beat Ruben to is not only should you decide, what you're going to do with test results, but you should decide what you're actually going to have as your next step for either a positive or negative result beforehand. Not, oh crap,
Exactly
I really
what I
thought
was
it was going to be
saying.
this, and the CT comes back and it's not. What now? You should have thought of that ahead of time because there could be some planning done that actually would anticipate that. So those would be the 2 points I'd make on testing, Anton.
Dr. Weingart, you mentioned a 2% miss rate for serious potential life-threatening diagnoses. I mean, that used to be sort of the standard like 20 years ago, and then it seemed like that standard changed to about 1% about a decade ago, and now it seems to be like 0. And we all know that, if you're trying to get a 0 miss rate, then you end up ordering way more tests than you need to, and there's going to be a huge chunk of those patients with false positives and get more invasive tests with their complications, etc. I think it's hard to convince emergency physicians out there that they should be okay with a less than 2% miss rate.
I think that's misapprehension. I think that number is fairly well established, at least in the States, in both the practice patterns, but also in the legal system. A great boon was done by Jeff Klein and then the originators of the PERC score by actually really imprinting on the literature that a life threat like pulmonary embolism does indeed have an acceptable miss rate. And once that was put in the literature, it really verified something that we've all been pushing for a long time. So, whether you bandy around the number of like 1.8 or 2, there definitely is an acceptable miss rate. And the courts definitely have acknowledged that. It's understood that if you attempt to get to 0, the only way to do that is by testing every patient for every condition at all times. And that's obviously farcical. So no, there are people who certainly practice as if an acceptable miss rate is 0%, but that is not done by an external force. That is their own misunderstanding of how to practice medicine, I think.
That 2% miss rate is predicated by Jeff Klein as the point beyond which the harms of the test exceed the benefit. And I think that's a very useful way to frame testing. So, for example, my decision about whether to perform a CT of the brain on a person with headache or a CT of the abdomen on a person with abdominal pain depends to some degree on the harms of the test. The harm of CT is vastly different in an 88-year-old than in an 8-year-old. The pretest probability of a dangerous condition is very different in an 88-year-old and an 8-year-old. And those two factors combine to inform my decisions about whether to pursue, in this case, a CT, but the same paradigm can be applied to just about every important test. I often see folks ordering tests that really just delay the test of interest and don't change the patient's management plan importantly, and that test is often done because it's easy to get or because it's routine. The most obvious example is the plain film of the abdomen, which used to be done very commonly before the CT assumed its place as a prominent test in the management of abdominal pain. And in patients with abdominal pain who could have a dangerous condition, push the patient to CT. If the X-ray is negative, you're going to go to CT. If the X-ray is positive, you're going to go to CT. So if you're very concerned that the patient has a surgical abdomen and you want to get free air on your X-ray to get the surgeon down faster, skip the X-ray, which takes time, and just push the patient to CT because the surgeon is just going to ask you for a CT anyway. I've seen CT delayed significantly for plain films of the abdomen, to say nothing of the algorithmic way that we manage trauma with a plain film of the chest and a plain film of the pelvis, which takes valuable minutes in a patient who clearly, urgently needs a pan-CT to figure out the most important life threats and so they can be acted on.
When it comes to testing, we've talked about when to test, when not to test. I want to move on to when you get your test back and how to approach test analysis. So interpreting your test results. Dr. Strayer, how do you go about interpreting your test results, say, when you get back that white blood cell count of 16?
The most important way to think about tests has to do with whether they move you in the direction that fits with your existing management plan or not. So if the test result furthers my existing gestalt, it furthers my existing plan, great. The concern is when the test result is discordant from your existing plan. That doesn't mean you should discard your existing plan. It means that you should take the opportunity of a discordant test result to move from type 1 to type 2 thinking and ask yourself, do I have the right diagnosis? Do I have all the diagnoses? Do I have to point my management plan in a different direction?
All right. Simple enough. So far in the podcast, when it comes to how to think about complex non-resus patients, we've talked about history, physical, differential diagnosis, heuristics. We've talked about test ordering and interpretation a little bit. The next thing I'd like to discuss is how to best make treatment decisions. And I want to start off with the well-known saying, I believe originally uttered by the White Rabbit in Alice in Wonderland, don't just do something, stand there. Because sometimes the best course of action is no action at all. You know, in emergency medicine, we love to act and do things and procedures and give treatments, but we need to do the right things to the right patients at the right time. Dr. Strayer, when it comes to the decision to act or not to act, how do you make that decision?
Well, you've referenced in our discussions leading up to this recording a heuristic that I developed many years ago called the preferred error. The preferred error is a heuristic that allows you to make sense of a difficult decision point by considering what would happen if you were wrong in either direction of your decision tree. It basically asks you to consider which plan fails better. So, for example, if you are considering intubating a patient who may or may not need to be intubated, this is a common conundrum that in many cases can be reasonably answered either way. The way the preferred error directs you in this case is to consider, if you don't intubate this patient right now, what would be the potential consequences if your decision was the wrong decision? Conversely, if you move forward and intubate this patient right now, what would be the potential consequences if that turned out to be the wrong decision and that patient actually didn't need to be intubated? And when you compare the consequences of your choice being incorrect, that often can very usefully inform your decision about whether to move forward with your plan or not.
Yeah, I would have no disagreement about that. In fact, I've formulated it basically the same concept as you choose what fails better. It's not enough to succeed, but what in failure mode will actually lead to a safer outcome as part of your decision. I think if I had to answer the question, Anton, what has changed in my practice since it's become far more prominent as an acceptable pathway is letting the patient make the decision. And shared decision making was, a real paradigm shift in emergency medicine because, there was a time where the medical legal thought was patients are uninformed, they're not allowed to make decisions, and to do so would put you at risk. Now, since it's accepted, anytime I have a dilemma on treatment, I'm like, wow, should I admit or not? Should I admit or not? As soon as I realize I'm troubled, then it means there is no clear answer. And then I might as well just find out what the patient wants to do and give them the full range of information they could use and then let them make the call. And that just took so many difficult decisions out of the mix.
I find that the shared decision-making comes mostly into the cases where I want to do less, but I feel like I could be blamed for doing less later. So if I really don't think that this person needs a CT scan, or I really think this person should go home, but I know that many other doctors would do that CT scan or admit that patient, that's when I put that shared decision-making into effect.
Shared decision-making, I think, is totally key. I use it in my practice all the time, but there's a lot of dangers in doing shared decision-making wrong. I mean, there's so many times I've seen the emergency doctor doesn't particularly want to do an LP for whatever reason when maybe they should, and their quote-unquote shared decision-making is talking to the patient about how awful an LP is, and then it's suddenly shared decision-making that the patient no longer wants an LP. So I think we really have to be true to ourselves and what we truly think is best for the patient when we go about shared decision-making.
Agreed. Yeah, no argument there.
We've talked about how to think and what to do just before a shift in part 1 of this 2-part podcast, and how to think what to do during a shift. But what about after your shift? It was Charles Darwin who said, "Ignorance more frequently begets confidence than it does knowledge." In other words, it's dangerous not to embrace lifelong learning. If you know about the Dunning-Kruger effect, you'll know exactly what I'm talking about. It's dangerous to think that once you finish your residency and have practiced a few years that you've learned everything there is to know to be a great ED doc and have supreme confidence. It usually happens at about 5 years out, I find. Or maybe even after 20 or 25 years of practice, you think you might not need to keep up. Remember that cerebral atrophy starts in our 30s or 40s and then ramps up even more around age 60. So we might get wiser with age, but not smarter. And the Dunning-Kruger victims and these older docs who don't exercise their brains are precisely the docs who have a higher chance of being poor performers. So with that in mind, Dr. Betzner, what can we do after our shift is over to up our mastery of emergency medicine and avoid becoming an overconfident poor performer? You had mentioned already reviewing all your cases. Anything else or to elaborate on that?
Yeah, I mean, that's my main and most powerful form of CME for sure. So I do 100% case review on every patient I see. It's the routine stuff where the learning is, by the way. It's interesting to read about sick folks, but it's the ones that you didn't see coming is really where the true learning is. And there's pure gold there. I mean, I read those surgical reports, discharge summaries, the consultant reports. I look at microbiology. I look and see how ortho fixes things. All that kind of stuff is important because I can have better conversations about patients with respect to what to expect as well, because I've built that library in my head. You need some method of keeping on top of what's new. And I think staying engaged and doing CME and doing lectures, coming to conferences, giving talks to other people forces you to stay up to date, because if you don't, you look like a turkey when you're on the stage. So all of those things, I think, are really important. And the older you get, the more important it is to stay up on it and on top of it.
Great. I want to talk about a few other things after your shift to help with how you're going to behave on shift or how you're going to think on shift. There's another post-shift deliberate reflection activity that Andrew Petrosoniak talks about, and that is the decision-making journal. Dr. Weingart, I think you've spoken to Dr. Petrosoniak about this. What is a decision-making journal? How do you do it, and why does it work?
Yeah, so Petro's concept of the decision-making journal, I encompass in a generalized idea of a commonplace book. Ben Franklin spoke about this. It's a book you're going to put all your reflections of little tips, little things you learned, and those things disappear. We think they're going to stay in our mind and be available. It's just not true. There's just too much else up there. So, one of the things that go into a book like that is, I did this, here's what happened, I didn't particularly like what happened, and then a real reflection while you're at home, not in the midst of a shift. How would I have done that differently? Let's mentally simulate that and see what could I have done next time. And I'll try that out and then see if it works. And then that should go into that commonplace book as well. Now, this might seem, I'm not going to keep track of all this. Well, if you want to be a good clinician, you probably should. If you figured out a great new way of doing things, you probably should put it down somewhere. And, like Rube and I, you could have a very comprehensive electronic version of this. You might even disseminate it to the public. You don't need that. It could just be in like a marble composition book. But you need somewhere to put thoughts on things that you have learned, things that you think did not go as well, what you plan to do in the next iteration of that, and be able to go back and review that on a regular basis. So that's mostly what Petro is getting at with his decision-making journal.
Yeah, I've started doing a decision-making journal. I found it absolutely invaluable. Another Petro gem is what he calls the pre-mortem. It's like a post-mortem or a debrief after a real case, except you discuss solutions to a theoretical decision gone bad before it even happens. Do you use pre-mortems? Can you give us an example of a pre-mortem, like how they work?
Yeah. So, this was actually coined and created by Gary Klein, who created recognition prime decision-making, which is the cognitive process by which people like us, like fire ground commanders, like special forces, actually use to make rapid decisions. And it's how our system of our mind actually works. The premortem, in its simplest form, is, the postmortem is when you already screwed up. The premortem is, let's think how I'm going to screw up before you actually make that mistake. So when I said at the end of every patient's documentation, I asked myself, how am I going to get M&M'd? That's what a premortem is. You're asking yourself before it goes bad, what am I going to miss? What is going to get me called by the clinical director tomorrow? That's what a premortem is. And you could do this with anything. It's very nice on sick patients to actually announce it to the whole team. Hey, folks, what are we missing here that's going to have this patient decompensating an hour from now? That's a premortem. So it's simply doing the work of getting, the scathing reviews that happen in an M&M of your behavior before that behavior ever happens.
On a very granular level, that's incorporated into the preferred error, where you just ask yourself, well, how will this plan look if it's the wrong plan? How can this plan fail? I'll also add that with regard to augmenting your clinical acumen, I've found nothing more valuable than case reviews. And I've been involved in my departmental case reviews for many years, and I've also done a lot of reading of journals and podcasts and all that stuff. And I am quite confident that my clinical skills have improved far more as a result of looking at and being involved in the QA process for my department than in all of the didactics that I've been a part of over the years. When you do a lot of chart reviews and case reviews, you start to approach your patients from the perspective of the person who is looking at your chart later after it's been referred to them because the case went badly. And there is a way in which that can become overly defensive, but I have found that it makes me much more attuned to the pitfalls that many of my colleagues have fallen into. Better to learn from others' mistakes than your own.
Oh my gosh, I can't agree more. I ran M&M for 8 years. There's no more valuable learning experience in my career than that. And you don't have to be the person running it to take advantage of that. I think every department should have a morbidity, mortality, or whatever you want to call it, committee. And if you could get together over some beers and discuss the cases, it will be a fantastic learning experience, and you'll actually be, donating your time to your department, which is necessary in some form in most departments. So yeah, I can't agree more, Ruben.
In part one, we had talked a little bit about simulation in your own mind when you're at home and actually visualizing what you're going to do for a certain procedure, say a halo procedure, a high acuity, low opportunity procedure. If you actually simulate it in your mind multiple times, that you're more likely to learn it better and perform better when you're in the emergency department. In terms of actually doing this, when to do it, how to do it, any tips or tricks there in terms of mental rehearsal or invisible simulation, whatever you want to call it?
Sarah Gray actually, I think, really did a service for people when she told us that she was putting on her calendar, each month a high acuity, low opportunity procedure, and then she'd practice it. And for some of those things, it's going to be test trainers. You could 3D print them. You could use them in a simulation lab. For some of them, you're not going to do that on a thoracotomy necessarily. They usually don't have a model for you. You could just do a mental simulation. You could review all the steps. You could watch videos. But that check-in, on a regular basis on your calendar, I think so many people I've recommended it to have adopted it, and I love that. And then when you have a case that you're like, well, that went okay, but was I really doing it that well? Then doing mental simulations on that and all of the auxiliary gathering of additional materials, maybe even asking a colleague from another service how they do this. That's the mark of someone who wants to gain true procedural excellence.
The other thing I do is pay attention to our resident schedule. They go to the cadaver lab at least yearly to do a variety of things, including thoracotomy and burr holes and all kinds of stuff that, super, unlikely to happen. They give us the opportunity to go with them, which is good for the residents, good for us too. So take advantage of those. And I think teaching courses on high acuity, low chance of doing it procedures is important too. If you have the opportunity to teach airway courses or procedural courses, do that, because you're going to be surrounded with doing that procedure over and over again all day long. And that sinks in. So take advantage of those opportunities. It's good for you and good for the learners.
One of the other home activities that we discussed a little bit in part one was doing meditation. It's easy enough to say, you should meditate regularly and then learn how to meditate, and that will help to decrease your stress at work and maybe even help your stress at home as well. But Dr. Weingart, could you kind of describe how you actually do this? How would you improve your attention and your memory and your peak performance in the hospital by meditating? Like, what do you actually do?
Well, there's what I do, which I, don't recommend at all. I mean, I'm at the stage now where I'm meditating, between 60 and 90 minutes each day. That's surely not a, reasonable recommendation for most people out there. And it's completely unnecessary depending on your goal structure. If what you want, the best thing I could say meditation offers is a separation between stimulus and response. It gives you the opportunity to now not have reflexive negative reactions to things like annoying consultants, difficult patients, et cetera. You get a few beats to ask, well, what would be the safest, the nicest, the most caring response rather than a reflexive response? And if you want that, I think the amount of meditation you actually need is much, much lower than, what I'm describing. So I think the optimal level is somewhere between 8 or 10 minutes a day once you actually get into the practice and you're not having those entire 10 minutes just disappear, even trying to get comfortable in your seat. But in its simplest form, breath following is what I recommend to all beginners. Sit in a comfortable chair. It's going to be really tough to sit without back support at the beginning, so don't do it. Just find a comfortable chair you're not going to fall asleep in and follow your breath for 10 minutes. If you do that on a regular basis each day, and the consistency is probably even more important than the timing, you will start seeing salutary benefits after about, 6 weeks, 8 weeks. And the benefits you're going to see is you're going to be less reactive. And that alone is an enormous boon to emergency medicine practice.
Great. Simple, easy. I wanted to talk about imposter syndrome because many of us strive for perfection and we don't perform to our expectations, and our inner voice will creep in telling us that we're not good enough. And for a few physicians, this might actually even ruin their career. I suspect that you guys don't suffer from imposter syndrome, but you've probably mentored some people who might have imposter syndrome, and it's certainly quite common based on the conversations I've had with other emergency physicians. How do you suggest we prevent imposter syndrome from finding its way sort of into our heads and causing negative outcomes for us?
Follow your patients, see what happens to them. I'm going to keep harping on this over and over and over again. I've had lots of young docs coming to me that it usually follows a bad case. They have a bad case, they have a bad outcome early on, and they're devastated. and they don't think that they're fit to practice medicine anymore, let alone emergency medicine. It's really terrible when you see that happening. And it's happening more often now because our work environments are getting so increasingly awful. And people are missing things more because of all the things we just talked about, the inability to do proper exams, the inability to take enough history, all of the things that need to be done to try and prevent these disasters are being jammed down our throat in quantities that we just can't deal with. So follow your patients, see what happens to them. You're going to build a brick around yourself of confidence and knowledge that you cannot get any other way. And, every resident I've had this conversation with, them kind of got them going on this process that I personally use to do all of that, has gotten back very favorably, that they're feeling better about themselves, usually within a few months. So that's what I have to say on this. I think it's incredibly important.
Anton, in our burnout course, this is one of the things we deal with. And I don't know if you could make the assumption that just because the three of us are where we are, that we don't have imposter syndrome. I think you'll find many experienced, remarkable doctors who do. And I found that in the people that I've dealt with burnout, which I think is representative of the general population, you either have imposter syndrome or you have another pathology, perfectionism. And generally you fall into one of the two. And I don't have imposter syndrome because I do have perfectionism. And if you have perfectionism, then you are so hard on yourself that it's very difficult to have imposter syndrome because you will not relent until you're at the point where you are performing at the level you think you should. But you generally have one of those two pathologies, and both of them are pervasive, and both of them really do predispose to burnout. So I think pretty much everyone in emergency medicine, my guess, would have one of those two unless they've really worked on getting past them. And even then, you just changed from a maladaptive pattern to a adaptive pattern. And I'm pretty happy where I am right now on my perfectionism, but it could be just as deleterious and just as burnout inducing as imposter syndrome.
That's a good distinction to make between the imposter syndrome and the perfectionism. I'm sure pretty much all of our listeners can relate to one of those too.
I'm going to make one other thing. I think we also need to teach our residents early on and young docs early on that humble pie needs to be on the menu. And it needs to stay on the menu. And if you think you're not going to eat it periodically, you're in the wrong profession. We're going to make mistakes. It's going to happen. It doesn't matter how perfect you think your practice is. It's going to happen. And so we need to inoculate people against that to some degree too, to just accept this is the way medicine works. And you need to own those mistakes. You need to go and talk to the people who have been affected by those mistakes. You need to apologize and you need to move on. But as soon as humble pie is not on the menu, it's time to retire immediately.
Well said. Yeah, that's closely related to the idea of emotional resilience, which I think is the last sort of micro topic I want to cover in this marathon podcast. And Dr. Weingart, I'll ask you, how do you train for better emotional resilience in dealing with adversity so that you can not only work better, but have a more meaningful life in general?
Ooh, yeah, that's a tough topic. First of all, accepting that you're supposed to make mistakes, that you can't be in a chaotic, difficult job like we're in without that is, I think, the first step to resilience. The second one is what Mike just mentioned, which is when you make a mistake, you need to own it and figure out why it happened and how you're going to fix that. And then I think we've lost, I'm sure every generation says this about the one below them, much akin to what was alluded to earlier, but I do think that resilience has been off the table in our current crop of upcoming residents, that, hardship is a really beneficial thing for building the capability of handling difficult situations. And difficult situations are our bread and butter. And we're at the point now where even constructive and well-intended, I would hesitate to even call it criticism, feedback, well-intended constructive feedback is looked at as a ego assault, and not across the board. And, I'm certainly not going to paint an entire generation with this brush, but I think we have lost the idea that you are supposed to have difficult, emotional, and contextual situations, and then you're supposed to grow from them. And that post-traumatic growth is what makes us stronger clinicians and stronger people. And without that, you're not going to get anywhere.
I think that what I've noticed over the years is what I refer to as either the vigilance pendulum or the emotional pendulum. And it's easier to understand with the vigilance pendulum. You have a certain style of practice, a certain pattern, and then you make a mistake, or even if you don't make a mistake, one of your patients has a bad outcome. So the effect that has on you is it causes you to increase your vigilance in similar cases for some period of time. So you didn't order a D-dimer on a patient who might have had a PE. You decided not to. You discharged the patient ended up having a bad outcome from a PE. You're still going to start ordering a lot of dimers over the next few months. Your vigilance pendulum is swinging one way. And then you're going to just notice a lot of negative CT scans, more and more and more. Even subconsciously, you might start to know this. And then your vigilance pendulum starts to swing back the other way. And eventually, it's going to swing back too far, and you're going to make another miss. You're going to have another miss. And so we go from point to point on the vigilance pendulum. And what happens over time, the vigilance pendulum continues to swing throughout your career. But as you gain more experience, the magnitude of sway in the vigilance pendulum becomes smaller and smaller as you hone in on your best practice. That same paradigm applies to the emotional pendulum that is so important in our work and dovetails into what Scott just mentioned about how important it is that we experience not just highs but lows. That's just part of becoming a proper, well-rounded person, not to mention a well-rounded emergency doc. So when you're confronted with an emotionally difficult situation, like a big miss, or even if you didn't make a mistake, just pronouncing a child dead and having to tell the family, these are devastating moments. And they affect you profoundly, and they push your emotions in one direction on a pendulum. And then over time, and often it's just time that does the trick, the pendulum starts to swing back, and you assume a more adaptive or normal posture, emotional posture. And maybe you'll get a little bit too complacent. You'll get a little bit too cocky. You'll leave humble pie off of that menu. And then another emotionally traumatic situation occurs and the pendulum swings back. But over time, have confidence that the magnitude of those pendulum sways will get smaller and smaller, and you'll arrive over time to a place of emotional resonance that hopefully will feel positive, will be positively valenced continuously or at least most of the time.
There was so much wisdom in what all three of you just said. I think that's a really good place to head into our wrap up, because that will provide a lot of our listeners a lot to think about and to reflect on themselves. You know, we covered a ton of ground on these two podcasts on the EM mindset and how the expert thinks. I hope that you took away some strategies and ways to help improve how you think as an emergency provider, a bit on what you do just before a shift, how to sharpen your mind during a shift, how to think before, during, and after a resuscitation in complex non-resus cases and outside the walls of the ED at home. I'd love to hear our listeners' thoughts on anything we've discussed in these two podcasts and any of your own strategies to be better at what you do. Just post your comments on the EM Cases site at the bottom of the show notes for these podcasts. Thanks so much, Dr. Weingart, Dr. Betzner, and Dr. Strayer for your time, your insights, and especially for your inspiration to us all to be better emergency providers and the best that we can possibly be.
Always a pleasure, Anton.
Pleasure. Thanks very much. Good talking to you guys.
Enjoyed it so much. Thanks, everyone.